researcher in the Beatrix Children's Hospital, which is in Groningen. It's, for us, it's quite high in the north. For Canadians and Americans, it's just a couple of hour drives, of course, but for us, it's very far away. Still, he was so kind enough to drive the whole way to Amerongen to give a presentation about patient as partner, specifically in the disease which is in his heart, actually, the glycogen storage disease, one of the congenital diseases and a rare disease, as you'll know. So, Ruben, come forward. The floor is yours.
All right. Good afternoon, everyone. Thank you for the introduction. My name is Ruben Overduin, and indeed I'm a physician researcher at the University Medical Center in Groningen. First of all, I would like to say thank you to the organization for having me and presenting me the opportunity to talk a little bit about my work. I will talk about this project here. It's called GSD Value, a standard set of person-centered outcomes for people with liver GSD. And I want to talk about this because for me it showcases how patients act as our partners, but also how VBHC principles can be applied also in rare diseases. I have no disclosures for today, and I will talk about three things in this project. I will tell you why we do this project, how we did it, and also what our result is. But first, in short, I see that it's a little bit smaller than I intended, but in short, what is GSD, or glycogen storage disease? It is a rare inherited metabolic disease. It occurs around 2 or 4 patients per 100,000 live births, and it affects the glucose metabolism. In short, on the left, we see the healthy situation where the glucose that we eat or the carbohydrates that we eat, those are stored in the liver. And it acts as a temporary source of energy to keep our blood glucose levels normal in the hours after eating. In people with glycogen storage disease, this storage is broken, so either the formation or the breakdown of the storage unit, glucose is stored as glycogen, that malfunctions. So what happens are two things. One, there's a buildup of glycogen in the liver, which is toxic for the liver, but also there's not enough glucose available for the blood. So people with GSD, they can have really low blood sugars if they don't eat around the clock. So actually they need to eat every 2 to 3 hours, even more often, to keep their blood glucose levels okay. But okay, why we are doing this project GSD Value for these people? Well, to explain that, I have to go back in time and explain how patients with GSD are actually our partners. We go back to the 70s and 80s, way before I was born. But those were the times when the first GSD patient organizations were formed. Because it is a rare disease, there weren't that many people who had it, and through these organizations they came into touch with each other and they can share experiences. And they learned, well, there's not so many expertise on this disease, but also there was not a single patient that received actually the same treatment. So what they did then, in the 90s, they thought, okay, we need to aggregate our expertise and we will start hosting conferences. Conferences like these, where we invite all stakeholders together and we physically bring together all experts. And that helped, and they asked the experts, well, please make some guidelines that, well, all of us can get the same treatment. So that's what they did. In 2002, the first ones were published, and those were made by the physicians. Then a leap forward in 2016, also companies started, and companies started to make clinical trials, and they also decided what outcomes to look at. But that was done by the companies, still not by the people with GSD themselves. In 2020, a former colleague of mine, he had a project in which he, together with the patients, made a research agenda, priorities, what to be researched in the coming 10 years. And one of those priorities was to make a consensus outcome set. So together with all stakeholders, including the patients, what is important. And that is what I am doing now together with Value-Based Healthcare Center Europe, or actually the decision group. And I want to make it a little bit around, so patients are our partners, okay, but I want to make the patients central in this, and actually we as healthcare providers, we are the partners of our patients in this. So that is why we are doing this project. Now, how we are performing this, it started with the stakeholders, and we needed to bring together stakeholders, and we wanted to do it globally. So we invited everyone that we knew, and they invited also everyone they knew, and in the end we had around 74 people from 25 countries, which we can see here. Yeah, there it is. We have 52 healthcare providers, 25 patients, and 6 companies involved. And also some patients have a double role because they are also healthcare provider. Then we selected all possible health outcomes through literature, through expert opinion, published outcome sets in other diseases, and in the guidelines I previously mentioned. And together with the stakeholders, we selected all relevant outcomes. And through discussions, we reduced it and reduced it and reduced it again. And we had a consensus on, for now, a preliminary outcome set of the 15 most important. We are not yet finished with the project. It is due in the next 2 months, but this is where we stand. And I want to show you what these outcomes are. So this is the final outcome set, what it looks like. And I have highlighted 2. The first one is the time to treatment of intercurrent complications. And the other one, actually it is sub-tier 4, the disutility of care. I highlighted these because, well, they showcase why these are important in rare diseases. So the time to treatment of intercurrent complications, because it is a rare disease, not many physicians know this disease or know what a complication looks like, or if they know it's a complication, know how to treat it correctly. So there are a lot of steps where there could be delay, and we hear it often and often that there is much too much delay. So that is why, in the end, it was deemed very important to include this. The other one, the disutility of care, this is something I think Hannah knows very well. What it is a continuous glucose monitoring system. People with GSD use this, but most often they don't have access to it because it is not reimbursed, and it is only reimbursed in most countries for people with diabetes and not for people with GSD. And this is just one example, but there are many, many more. And this is also why we included this as an important outcome. So this is why, how, and what we did in the project. As a conclusion, I think it is, well, I want to say patients are our partners, but actually we as healthcare providers and stakeholders, we act as the partners of our patients. Patients are also the driving force in research and in improving outcomes. And lastly, also value-based healthcare principles can be applied in rare diseases as well. I want to thank the 2 patient organizations who fully funded our project. This is also, I think, an example how involved the patients are, all stakeholders, and the Decision Institute, our project partner. I want to thank you all very much.
Thank you so much, Ruben. Stay here for a second. We have time for 1 or 2 questions. Also online, if you want to have an online question, just put it on the chat, and I'm sure Claudia or one or other of the others of the organization will give me the question. Any question from the audience about this project? Maybe I could start. You were showing the map of the participants of your conference, and that most of them, of course, say rich, highly developed countries. But we had in the presentation of Hannah and clear advocacy for we should do something about disparity in healthcare provision. Do you see huge difference in less richer countries than richer? I mean, I imagine in Holland it's easier to do that if you're than in, say, Romania or South Africa.
Yeah. Thank you very much for your question. I think it is a really important question that there is equitable access, and indeed most of the countries that we have included are well-developed countries, but there are also some less well-developed countries where there is a struggle with access to healthcare. I just have some anecdotal evidence, and well, in South America there's also less countries with less experts available, and I heard of systems where local physicians are in contact with experts from America or from Europe, and well, using Zoom or using teleconference calls, they share their expertise. So not one-on-one from the expert in Europe to the patient, but the expert in Europe to, well, a physician locally who then helps the community with 1 or maybe 2 GSD patients. I think that is one of the, well,